Bariatric surgery is a term that we use for the surgical approach to obesity. And in fact, it probably should be just called obesity surgery. There are 4 types of bariatric surgeries worldwide, 2 that are most common in British Columbia. The first is what's called a laparoscopic banding. And remember, laparoscopically means that you make 5 small incisions in the abdomen, and they literally sort of pump air into the abdomen to sort of blow it up like a balloon. And then they're able to go in with a camera in one hole, some instruments, etc. And the surgeons look on the screen, and actually it's almost like playing a video game where they look inside, and the surgery is done through these small little holes. The instruments are actually put in and out. The beauty of laparoscopic surgery is that you only have these 5 little incisions, and a patient can go home even the next day or 2 days later. So in the old days, we used to do surgeries which were called open surgery. So they'd have a huge incision from stem to stern, so to speak, and that big abdominal incision really made it very difficult for people to mobilize, and it was a more significant amount of healing. So all surgeries nowadays are done laparoscopically if they can be. In fact, it's rare that a surgery is converted to an open surgery, which allows for very quick healing, and it allows for minimal pain, and people usually leave hospital a day or 2 after their surgeries. The 3 types of surgeries that are most commonly done in British Columbia, the first is called laparoscopic banding. And what happens is a small band is placed around the top part of the stomach. It acts a little bit like a vice. And a little port is then connected from that band that sits just under the skin of the abdomen, and it's able to be injected with fluid so that it clamps down on the band and makes the band tighter or looser depending. So it literally sort of, quite honestly, alters the size of the stomach. The advantage, of course, is that it can be removed. But there are some significant disadvantages to this. One, because the entire system is still, quote, intact, it doesn't really affect any of the hormonal changes that really might be causing the obesity itself. So all you're really doing is wiring a person's jaw shut, so to speak, lower down. The other disadvantage of a gastric banding is that often because the stomach entry is a much smaller hole, it's really hard for patients to get food into it. So the band itself, which is supposed to act like a barrier, actually promotes pretty unhealthy eating because it's hard to get protein and vegetables through that band. And patients often tell me that milkshakes go down very nicely. So it really creates more of a dysfunction around food than an actual proper approach. And the reason why bands used to be so popular was because we used to think that obesity was about a math equation. And if people would just eat less, we would allow for weight loss. And so that's where many of these previous treatments really were thought to be effective. So the band being one of them. We also have there's a new technique where they literally put a blow up ball in the stomach. It's temporary, it can be removed, but it's the same kind of idea that it unfortunately plays into that old thought process that's wrong, that this is an eat less, move more concept. So most provinces in Canada now no longer cover the band under the medical service plan. So you pay for a band, which is another disadvantage. So in British Columbia, for example, paying $18,000 to essentially have your jaw wired shut lower down just because it's, quote, removable or a temporary surgery is, in my medical opinion, not just a waste of money, but the studies actually show with bands that 80% of patients gain the weight back at 5 years. So if a patient comes to see me and they want to talk about a band, 9 times out of 10, I'll try and talk them out of it. The next surgery is called a sleeve gastrectomy. And a sleeve gastrectomy is one of the most common procedures that's done in North America. In fact, 60% of surgeries that are done for obesity or bariatric surgeries are sleeve gastrectomies. And what we do is, again, laparoscopically, they go in and quite frankly, they remove 80% of the stomach and they turn the remainder of the stomach into what looks like a banana. It was called a sleeve, but I joke with my patients that it should be called a banana gastrectomy because that's exactly what the stomach looks like. So food goes in the mouth, down the esophagus, and into essentially a stomach that's the size of a banana. The stomach goes from being about 25, 26 ounce capacity to something that's about a cup, so about 8 ounces, if that. Half a cup, depending. You have a much smaller amount of food that can go in the stomach, which again plays into that idea of it's a restrictive procedure. But the thing that people need to be aware of is that one of the most powerful hunger hormones in our body is called Ghrelin, and Ghrelin is produced by the stomach. And so when you do a sleeve gastrectomy, not only do you make the stomach smaller, but Ghrelin levels plummet within not even hours of surgery, and literally what you're doing is resetting a broken system hormonally. So it's like taking out a hormonally charged piece of tissue from the body and maybe resetting a system. And it's why we see people who go into hospital, for example, on insulin with diabetes, sugars in the 10s, and come out of hospital 24 hours later off insulin with sugars in the 6s. And they might even, in the course of, let's say, 2 weeks after surgery, lose as much as 30 pounds, which, if you do the math, it doesn't quite compute. It's not math, it's chemistry. Patients with a sleeve gastrectomy on an advantage point lose about 1/3 of their body weight. With the proper behavioral and medical management before surgery and long-term management after, 80% of patients keep the weight off at 5 years, as opposed to the opposite with a band. It facilitates the kind of foods that you can still have Christmas dinner and you still get to eat protein. Sure, you have a much smaller stomach, and it's like going from a 5,000 square foot mansion to a small apartment. You have definitely smaller real estate, and you have to be very mindful, for example, about the types of foods you're eating and the amount of nutrients and macronutrients that you're getting in. But realistically, it doesn't have the kind of sort of physical limitations to food as a band. And other advantages are you see a significant disease regression when it comes to things like type 2 diabetes, sleep apnea, high blood pressure, cardiovascular risk, other diseases, for example, like intracranial hypertension, which is higher pressures in the brain that we see. 95% of patients post-sleeve gastrectomy will have complete remission of intracranial hypertension. So a sleeve is actually a fairly simple surgical procedure that results in a significant treatment approach both for obesity but also for many of its complications associated with it. And it's those disease regression advantages that make it such an appealing surgery for many, because it's low risk but very high sort of medical health gain. In terms of risks associated with a sleeve gastrectomy, it's actually 3 times safer than a gallbladder removal. It's 5 times safer than a knee replacement surgery. it's 12 times safer than a hip replacement, and it's 25 times safer than coronary bypass surgery. So because of the nature of how the surgery is done, it's a relatively safe procedure. There are complication rates associated with every surgery, and with a sleeve, the complication rate is about 2 in 10,000 deaths, which is quite a low risk associated. When we think about it, what we also want to look at is what are the complication rates, for example, of a leak. So you can imagine that you're cutting off part of the stomach and sewing the stomach shut. Leak rates in Canada are about anywhere between 2 and 4%. And leaks are often fixed laparoscopically, and a leak really is what it sounds like. It's where the sutures didn't hold for whatever reason, and there's a leak of gastric contents into the abdomen, and we go through with patients exactly what to watch for. So if you're, for example, 1 week post-surgery, and within the first week or two post-surgery, and you start to feel significant abdominal pain, and you're flushing, and you're feeling really unwell, you get right to emergency. You tell them that you've had bariatric surgery, who your doctor was, who your surgeon is, and that you need a CAT scan. And that usually takes care of things quite nicely. So that's a sleeve gastrectomy. The third surgery is actually the gold standard, if you will, and it was established in the 60s. It's called a Roux-en-Y gastric bypass, and literally the bypass refers to the fact that what you do is you create a small pouch from the native stomach, and then you bypass the first part of the small intestine. So you cut the small intestine at where the first part meets the second, and you bring up the second part of the small intestine and attach it to that new little pouch of stomach. And then you leave the remainder pouch of the stomach intact so that it sort of produces digestive juices that kind of catch up downstream, and you almost create this Y picture. The interesting thing about the Roux was that the sleeve gastrectomy that we just talked about was born out of, it was supposed to be the first stage of a Roux-en-Y for patients who had significant obesity. They wanted to do stage 1 with a sleeve, and then they would go back in and do a Roux. And sure enough, the sleeve was so effective that most of these people, they thought, well, we'll just leave these people as a sleeve. So the advantage of a Roux is that you get much more significant body weight loss. So patients lose almost 50+% of their body weight. They have a far bigger hormonal shift in terms of the hormones that are involved with mediating obesity. So a sleeve reduces hunger hormones by causing a drop in Ghrelin, and a bypass actually causes a massive surge in fullness hormones, or what we call satiety hormones, because you're altering the anatomy of the small intestine. And the brain gets signals from the small intestine to perceive fullness. So it would be, for example, in your house, if you were redoing the plumbing and the electrical, you would get different signals, so to speak, to the system. And that's similar to how the Roux-en-Y works. It's kind of like a redecoration, so to speak. So the signals are much different. You also get, as a result, a much more significant disease regression. So particularly in people, for example, with type 2 diabetes, they have a much larger chance at causing a complete remission of their diabetes with a gastric bypass as opposed to a sleeve. And there's really interesting studies, one right now ongoing, looking at patients who've had sleeves versus bypass to see which one offers the most chance of what we call disease regression. And really all disease regression means is, how do we take your disease and help you start over to where you didn't have it before? So we'll literally take you back to 3 years before you were diagnosed, let you go through the process all over again. And you can imagine if you're someone who had diabetes has had diabetes for 15 years and you're now on 3 medicines and insulin, let's say 100 units, to be able to go into hospital, to have a surgical procedure, that the day you leave hospital, you're not on insulin. Maybe you're on 1 diabetes medication, if any, and you have normal blood sugars, and your next blood test shows you that within 6 months, you actually have complete remission of your diabetes, off medication. My patients all say, oh my God, that's magic. And I joke back, well, no, that's medicine. And so that's the advantage of a bypass, that you get significant disease regression with much more significant weight loss. Disadvantages, you have a higher risk of malabsorption because you're literally bypassing the small intestine. So that's where a lot of vitamins and nutrients are actually absorbed. And as well, you have a much smaller pouch. So we talk about the size of the stomach post-sleeve as being about a half a cup to a cup. The size of the stomach post-bypass is about 2 to 4 tablespoons. So it's a much smaller amount. With both of these surgeries, you have to learn how to eat all over again because volume is not your friend and food needs to be nutrient rich. It has to be kind of the concept of protein first. With both surgeries, people have to take vitamins and supplements for the rest of their lives. And realistically, with both surgeries, essentially what we're doing, full disclosure, is giving you a new disease. So we're going to trade one disease, obesity or whatever its complications are, for this new disease, meaning you're going to have a much smaller stomach. Your gut is not going to look like the gut you were born with. We're going to physically alter it permanently, and you're going to have a malabsorption issue, or you won't be absorbing food or digesting food the way you used to. And so I always say to patients, if you're going to make that trade, make sure you're trading up.